So today's lecture is going to be under, or over rather, not under, over your clinical lab studies. So this is for Monday, August 10th. I have some good news for you. As I was grading the MREs, and I still have some yet to grade, I realized that MRE 2, I believe it was, that you just completed. Yes, MRE 2 really should have been done after this lecture. So with that being said, I'm going to kind of relook at that. Basically, instead of the MRE being worth, I think it was like 43 points, because pretty much after question number 12, a lot of these those other questions from like 13 and beyond really are covered in this lecture. So I'm going to go ahead and change the total points worth to only 12, and then I'm not going to take off any points for the ones that you got wrong after, 13, question number 13 and beyond. Though I highly recommend, I'm not going to take like the MRE down or anything. I'm just going to tweak all the points in that, but it's a good study guide. That MRE is a good study guide for you, so if you can print that off, and now you have the correct answers if you got them wrong, to study for your final. So, all right. So clinical lab studies. So we have different types of lab studies that we want to look at as we're assessing our patient. Kind of, obviously gives us an idea of their general health, gives us some baseline numbers. We, want to identify those numbers or values that are out of range, out of normal range, and, hopefully it will give us a clue as to what's going on with our patient. Again, it's always kind of like a little piece of the puzzle. Some numbers, if they're abnormal, can indicate infection. All those different values are connected to an organ or some kind of system process in our body. It also can determine if the therapy that we've been doing is effective. Alright, so there's several different tests that they can run. Some of the more common ones are under what we call our formed elements. Okay, so you want to know which ones are your formed elements. And your formed elements, and you probably went over that part in A and P, are your white blood cells, your red blood cells, and your platelets. Okay, so those are your formed elements. And then your electrolytes are located in your plasma. Okay, so so that's another different type of blood test. So we'll talk about like a CBC and what that all involves, a complete blood count, and how that kind of subdivides out. So just know that your formed elements, again, are your white blood cells, your red blood cells, and your platelets, because I assure you, you will have a multiple choice question about picking out which ones. So your plasma is not a formed element. Alright, so we have reference ranges. Again, we want to, so normal, we try not to say normal because some people's are always maybe a little off by a point or two or something, or a tenth of a point. As long as they're not symptomatic, that might just be where they're at. So just keep in mind it's a reference range. We have to always look at the rest of the picture too to determine if it's something that's alarming. So when they they look at certain populations of people, and that's kind of how they decide what are these reference ranges. They take in consideration age, gender, race, ethnicity, and you will see that depending on like Quest Lab or LabCorp or all the different labs, you'll even see it in your textbooks where there'll be a little slight variance on what is considered the normal values or your reference ranges. So don't kind of freak out about that. And then even different disease processes will kind of have like a certain baseline that's kind of like considered normal for that disease. So like a COPD patient, just an example, like their CO2 is often elevated. Their pH is compensated by their bicarb, so their bicarb is also elevated to offset that acidosis. But that is kind of considered normal for them, for their disease process, because that's where their body has adjusted and compensated for that. Also, patients that are chronically hypoxic with the polycythemia, their hemoglobin and red blood cell count is up because of their chronic condition. So that's kind of normal basically for them. So just keeping that in mind. All right, the first thing we're going to take a look at is sputum. Okay, our lovely sputum. That's part of our lives every day. We wonder and worry about sputum. Most of you did really well on that question. Anyway, probably maybe you've looked in your book, which is fine. That's what you should be doing, but I just don't feel like you should be penalized for because I didn't go through this lecture part yet. So it's something that we're often asked to collect. Know this normal amount. We produce about 100 mils of sputum every day. That's just our normal. We swallow it, whatever. I mean, that's just what keeps everything moving. There's certain procedures for obtaining sputum. The best thing to do is to talk to your department and see what they do. A couple things that that I know off the top of my head that we definitely do is in the morning they like to do the AFB culture, so the acid fast bacillus ones. The AFB, when they're testing for TB, we generally try to get those samples done in the morning. They feel that the saliva or the sputum might be a little more thick in the morning. They generally like to have you brush your teeth or rinse your mouth prior to the sample to kind of get rid of some of that nasty stuff. If you're going to administer hypertonic saline is a really super salty solution that kind of draws out some of the fluid, so it helps to mobilize the secretions a little bit. We generally don't do that unless it's saying a sputum induction on an order, an actual physician order for sputum induction. And that's when we would use the hypertonic saline. And you always want to pre-medicate patients with albuterol for that, because it can really cause some bronchospasm. It's very irritating to the lungs. So we would generally pre-medicate with the albuterol, so they would take a nebulizer treatment. Then you would follow it with a nebulized hypertonic saline, which is usually given about 3% is what it comes up from pharmacy. Normal saline is 0.9%, so it's like 3 times as salty basically. And we want to try to get about a 3 to 5 cc sample, a good sample. So you want your sample to hopefully have sputum in it. You don't want it to have just spit. Okay, some people just kind of spit into it, and it's like that's just saliva, and the lab's not going to like that. So, but some of the things that we note while we are looking at patients' sputum, especially when we're suctioning or if they're coughing stuff up, you ask them, if there's a color to it. Sometimes they'll cough it into a tissue and show it to you. Sometimes they'll cough it into like a little basin and show it to you. But we're looking at, we're concerned with the amounts, the color, the thickness. Obviously, I don't go around smelling people's sputum, but certain sputum you can actually smell, like Pseudomonas has a really nasty smell to it. All right, consistency. So that is something that we definitely talk about. If it's thin or kind of foamy, thick, viscous is kind of more like gelatinous, and then sticky, tenacious. That's like the worst. Okay, so hydration status can definitely influence their sputum. And you think about our COPD patients that are often, especially end stage, kind of undernourished. I just finished the nutrition one. I don't think we go over it in patient assessment, but I know we do for sure in advanced patient assessment. Yeah, we really don't talk about nutrition, but we'll go over that in advanced patient assessment. They're malnourished, they're often dehydrated, and so their sputum tends to be rather thick. CF patients, they lack that enzyme or the release of that enzyme, so their sputum is really thick. Bronchiectasis, if you have bronchiectasis, which is a chronic condition, their sputum kind of has like this three distinct layers. And you can see how it's kind of nasty here. You got the sediment, or the kind of pussy layer that kind of settles out, and then there's a liquid layer, and then there's a foamy layer. So you may see bronchiectasis patients where they have a lot of secretions like that. Pretty gnarly stuff. All right, so we send the sputum down to the lab to look to see what's growing out, basically. So they want to identify it. They look to see whether it's a Gram stain. They put a different stain on it. If it comes back like a blue or purple, then it's considered Gram positive. If it's comes back red, then it's considered Gram negative. So it's kind of how they identify the different types of sputum, kind of categorize it basically. And then they look at it under a microscope. If it's rods or cocci, it just again helps identify. And then the sensitivity, so then they look to see, back when I took a micro class years ago, it was kind of cool. We had like these little discs that they'd spread like the organism on, whatever it was, and then they had these little tiny small dots of like penicillin or different types of antibiotics, and then you'd see which ones they grew around. If they grew around the little dot, or like they're like a size of almost like a little pill, even smaller. If they grew around it, then it wasn't sensitive to that. It was resistant. But if there was distance between the growth and the medication, then it was sensitive to it. So that was something that would kill it. So you have your Gram positive, generally is your pneumococci, and your Gram negative then is H. influenza. And unfortunately, as far as what antibiotics we use to kill these organisms, it's not as cut and dry as it used to be due to the resistance of some of the antibiotics that are out there. So that's a big challenge. As a general rule, Gram-positive pneumococci should be killed by penicillin. I kind of took this off the test anymore just because it really has changed over the years, depending on, we have these multi-resistant organisms out there. I'm sure you've heard of MRSA. I mean, there's a ton of them. Oops, sorry, I had to adjust the microphone. The other day, Victor, when he was at work, he was telling me, he goes, I think I've been exposed to almost every letter in the alphabet, because there's like MRSA, there's C. diff, there's VRE, that's vancomycin resistant, enterococca or something, and then of course there's COVID, and he's just like, I feel like I'm just like, ugh. Anyway, things to look forward to. Yeah, just proper wash your hands, wash your hands, wash your hands. Okay, wear your mask. Just be careful. Don't touch your face. Whatever you do, just don't touch your face. I have a general rule when I was always working. I did not touch my face. Above my neck, no, you just don't touch your face. I mean, if you absolutely have to, go wash your hands or something, or yeah, so use a tissue. Just try not to touch your face. And don't wear your shoes home. Leave your shoes at the hospital. I mean, I know with doing your clinical rotations, that's kind of hard to do because you're in and out of different facilities. But if you know you're going to be someplace for a couple weeks, maybe just ask them if you could, just leave your work shoes there, and bring a change of shoes, and then put them in a plastic bag or something to bring them home and throw them in the garage, because you think about all the stuff you step in. Anyway, so penicillin generally would be your choice of treatment for Gram-positive pneumococci. If they have to bring out the big guns, like if that's not doing it, vancomycin is another one. So some of these medications actually can't even be administered by mouth. They have to put in a central line. Some of them are really caustic, so they can cause damage to your veins and stuff, like in your arms. So they would put it in a line in your neck and just give it through a larger bore IV and get it into the body faster. And then Gram-negative H. influenza, that is generally, keep in mind, that's the organism that can actually cause meningitis. That is amoxicillin, or Augmentin, which is amoxicillin and another medication, the Z-Pak, which is erythromycin. I'm trying to remember, whenever we got exposed to meningitis, I forget, we had to go down to the ER, and they would give us the one dose. I'll have to get back to you on that. It was just like a one, was it Cipro? I want to say it might have been Cipro. Ciprofloxacin or something. We just get one pill. So, you know, they always document, you know, that's the wonderful thing about charting. You can go back to see who's taking care of these patients, and then if you accidentally, you know, or if you know, were exposed, then they contact you and you'll get a short course of antibiotics. And I know, I'm pretty sure it's Cipro, because I've had to be on it several different times. So it's just the one dose that I guess makes this okay. I have a interesting story though about the H influenza one too. I was really sick several years ago when I first started teaching elementary school. I mean, not like super sick, but just had like a really bad sore throat. I thought for sure I had strep, and I went in and they tested me, cultured me, came back negative. They sent it off to the lab, and we were just getting ready to go down to Disney with the kids. It was over like winter break, and I got a phone call after I'd gotten back. I mean, I did get better, but they called me and they're like, you actually weren't on the right antibiotic for that. You had H influenza. But I ended up recovering from it anyway, but it wasn't, you know, the proper antibiotic. They're like, how are you feeling? And then I look it up, I'm like, oh great, that was the meningitis bug. So anyway, I just had like a super, super bad sore throat. So if the bacteria then are sensitive to the antibiotic, it will stop the growth. So that's basically what that means. Like I was saying in those little petri dish things. I wish we had the ability to do that with micropima, but unfortunately I think it's only like a 1 or 2 credit class. When I took it, it was like, you know, like a 5 credit class where you had, you know, lab at least once or twice a week, probably once a week. Alright, move on before my lecture gets going here. Okay, so pleural fluid. So they also look at pleural fluid, and the biggest things that you want to know is whether it's kind of clear. If it's clear, it's considered transudate. Okay, it has less protein and cholesterol, so transudate is generally really more kind of fluid overloaded type of reason why you would have it. So like cirrhosis, you have inflammation of the liver, and those onconic pressures get messed up because those types of patients usually have low albumin, and that's what helps control those onconic pressures. So sometimes that extra fluid will go into the pleural space. Same thing with congestive heart failure. You have extra fluid, you're not able to you know, pump all your fluid efficiently. Your left ventricle isn't functioning as well. Or renal failure, where you're just retaining more fluid. So so low protein, kind of clear, pale fluid, not infectious, is your transudate fluid. Okay. And then your exudate is your cloudy, kind of nasty, more stuff. It's got usually infection is the reason for it. It contains more protein and cholesterol, so hence it gives it that cloudy look to it. Like I said, the causes can be infection, trauma, cancer, pancreatitis, any kind of inflammation in the pleura. So the way they get the pleural fluid out is through a thoracentesis. They put like a small needle into the pleural space with a syringe, and they draw it out. Obviously they want to know what the pleural fluid is made up of, so that way they can treat it better. The Leitz criteria is what helps determine that is what they're looking at, that serum protein ratio. So the other thing you would need at least a milliliter. I mean, it's something that you might possibly assist with, depending on your department where you work. And you don't want to put the pleural fluid in the refrigerator. You just want to take it right down to the lab. So it's basically caused by blocked blood vessels or lymph vessels, the inflammation, infection, or lung injury and tumors. So like I said, cancer is definitely CA, a big CA like that. Capitalized is always is cancer. All right. So what they're looking at then, so now we're going to be talking about histology and cytology. So histology is actually looking more at the tissue, okay, and then cytology is looking at cells. Okay, so histology, you're looking at the tissue. So if you've done like a bronchoscopy or where they've actually taken a pinch or like a little bite off of the tissue, or surgical biopsy, basically they're generally looking for cancers when they're looking at histology. And then cells, they're looking at the fluid. They go ahead and they smear those onto a slide. They dye them so they're able to visualize them better. Again, sputum, pleural fluid, needle biopsy. They also, during the, they may do a fine needle aspiration when they're doing a bronchoscopy. So a chest x-ray or a PET scan or a CT may indicate the need then for further intervention. So a bronchoscopy is one of the procedures that we'll do. They have different types of EBUS probes to obtain the samples that they need. So there's a peripheral EBUS. We'll talk more about that when we cover bronchs, but it's kind of cool. It has like this little radio probe on it, and it kind of has like a 360 view. So it can look at the lesion, and you can either get like a brush sample or a bite biopsy. The bite biopsy, then they probably look, that's more histology, because then you have a little piece of tissue. And then the fine needle aspiration can actually look at the parahilar lymph nodes, like around the hilum area, like the mediastinal area, all the lymph nodes. And then they use what they call a linear EBUS to do that. So I actually have a little added recording for advanced patient assessment that my husband did for me. He did about a 10 or 12 slide little presentation for me because he assists with the EBUS bronchoscopies at the in the lab at Good Sam's. All right, hematology. So now we're looking at blood. Okay, so hematology always means blood. So we can look at CBC, or we can look at platelets. So always when you think of platelets, you think of clotting. Okay, so did I talk about that? Hold on, I feel like I think it's actually coming up. It's all kind of muddling together in my head because I just did advanced patient assessment on this lecture probably about a week ago. So basically, hematology is the branch of medicine concerned with the study of the cause, prognosis, and treatment and prevention of disease related to blood. So hematology is always blood. And then again, as kind of like a little quick review, the two major components of your blood are your formed elements. So you need to know that, your red blood cells, your white blood cells, your platelets, and then your plasma. Your plasma does not have formed elements. It consists mainly of water and soluble substances, which include your electrolytes, your clotting factors, your immunologic factors, proteins, lipids, and hormones. I think this is out of chapter 7 in Wilkins. I'm trying to remember if the picture is in there, because I do have a different picture that kind of shows like I want to say it's like 45%, 55%. I think 45% of your, yeah. if you look at it, it's on page 126. So it kind of like, and maybe it's coming up here in the slide. I don't know if it is actually. Yeah, maybe it is. Yeah, it is. It's coming up. But anyway, it kind of shows you how they spin out the blood, or how the packed cells, and then your plasma, and how that's separated. So that kind of gives you a little bit of a visual there. All right. So plasma, almost every substance the cell uses has to be transported by that plasma. Your serum is then the remaining, is the fluid that's remaining when the blood is allowed to clot. So serum actually has immune factors in it. So when we're looking, this is the slide that I was talking about, if I was wondering what happened to it. So when we're looking again at the complete blood cell count, we're looking at those formed elements. So again, your white blood cells, so another name for your white blood cells is leukocytes. So make sure you know that. Red blood cells are erythrocytes, and then platelets, another name for platelets is thrombocytes. Okay, usually thrombus means clot, and then cyte means cell. Okay, so kind of leuko means white, erythro means red, and all the suffix there, cytes, means cell. So white cells, red cells, clot cells, basically, if you kind of look at the actual. And I would think medical terminology probably went over some of that too. So we're going to look at each one of these separately. The leukocytes, and there's a differentiation of each of those types of white blood cells, which I know was part of one of those questions on the MRE. And then your red blood cells, we'll be looking at the hemoglobin, and then the platelets. We'll be talking about those. This is just a little table from, again, chapter 7, so be familiar with these numbers. The ones more so would be like the first 4 there, what the normal values are for your white count, your red count, your hemoglobin, and your hematocrit. And then we'll define what reticulocytes are. Okay, so polycythemia, that was another question that was on there. It's basically an abnormal elevation of red blood cells. But why? Why do we have a normal elevation of red blood cells? The primary condition, which is generally not as common, is really basically a condition of the bone marrow. Something's going on with the bone marrow where it just feels like it should produce more a red blood cell, kind of more of a disease process, or maybe a condition, basically. Secondary is the one that we're kind of more concerned of, and that's the one that we're kind of, is most common, is where your bone marrow is stimulated to produce more red blood cells in response to hypoxemia. Okay, so we have, patients that are living at elevation, patients with chronic lung disease that are chronically hypoxic. Those types of patients will have secondary polycythemia. So their blood actually is thicker. So that's how their body has compensated for the reduced amount of oxygen. As they increase basically their carrying capacity of oxygen. They produce more hemoglobin, so they can carry more oxygen. Polycythemia can be dangerous though, because it makes the blood thicker, more viscous, and it increases the workload of the heart, and also increases the risk of clots. So they have to kind of monitor that. Anemia then is basically a reduced red blood cell count. It can result in a low hematocrit or a low hemoglobin. So if you have anemia, then you have the reduced ability to carry oxygen. The patient may feel fatigued, short of breath. In severe anemia, tachycardia can actually happen. Their blood pressure can be low, and it can actually lead to heart failure because your heart's trying to keep up with the oxygen demands. You have a lower capacity, so it's just beating faster to kind of keep up with the demands, the oxygen consumption demands of the body. generally it's just, an iron deficiency. As far as, hopefully an iron supplement will help them. You may see it in pregnant people, growth spurts in adolescents. Maybe something is causing malabsorption. They're not absorbing the iron like they should. Other causes can be chronic inflammation, that of the bone marrow can cause impairment of the iron regulation and red blood cell production in the bone marrow, so it's inflamed and it doesn't recognize the need to increase or to produce the red blood cells. So hemoglobin is the protein then that carries oxygen to the tissues. So be familiar with the normal values. That's grams per deciliter. Males generally always have a higher red count, a higher hemoglobin, and a higher hematocrit. They just do, I think, because they have just more body mass generally than we do than females. I mean, there's definitely some overlapping there in the numbers, but generally their normal ranges are a couple points higher. Their hemoglobin is the major component of red blood cells. It's also important in maintaining that acid-base balance that's acting as a buffer, and because that buffer then helps carry the CO2 away from the tissues to the lungs. So here's the little picture I was talking about, the hematocrit. So kind of splitting it up where there's like a little centrifuge thing that spins out the blood and the packed cells settle, and then it kind of separates from the plasma, sort of. I mean, kind of like the bronchiectasis sputum, the packed cells settle by gravity and the plasma's up on top. So in this particular example, it's kind of showing how 50% of the total blood volume is packed cells. And so the hematocrit then for that particular example would be 50%. So the hematocrit then measures basically the volume of those red blood cells, those packed cells, compared to the total blood volume. So kind of separating out red blood cells and plasma. So it's kind of like that percentage. And so it's the ratio of red cell volume to whole blood. So again, males are a little bit higher than females. And that's kind of where we would like to be. It's a fairly good size range of about 14 points there. If your crit falls, a lot of times you'll hear it just say crit versus hematocrit. If your hematocrit falls below 21% or your hemoglobin below 7 or below, again 21% or below, they may very well need to transfuse you, so, or the patient. Hematocrit, and here's another question from that MRE. So hematocrit can also reflect the patient's hydration status. So if you're dry, dehydrated, your crit's going to appear higher because it's like more concentrated. There's less plasma because that's mainly made up of water, so it's going to appear higher. And then if you're overhydrated or there's water retention, then you're having it more diluted, and so your hematocrit will appear low, or hemodilution. Okay. Yeah, so that was one of the questions that was on the MRE, so I'm going to take that one off too. So I just have a side note here. I wanted to kind of read it again. So if you have a trauma patient that you're just giving a lot of fluid to, you're not necessarily giving them blood, but you're giving them fluid to help maintain their blood pressure because it's easy and it's accessible. And I mean, usually if it's a bad trauma, they bring up blood too. But you might have, it might appear that the hematocrit is low because they're trying to replace the volume for your blood pressure more with fluid, saline, lactated ringers, whatever they need to do to get that blood pressure up. So, and then, they'll definitely, so immediately it may look like, especially if they're bleeding a lot, that their H and H are low, but then they'll go ahead and transfuse to get those numbers back up to normalize those numbers. But just keep in mind, at that point, then they have a decreased oxygen carrying capacity. So we may need to make adjustments on our end of oxygenating these people better. Okay, I know I'm going to go over an hour on this, I'm sorry. So here was a differentiation when I was kind of referring to on that one MRE test. So we have neutrophils, eosinophils, basophils, lymphocytes, and monocytes. But like I always make, for those of you that I haven't finished grading, I'll go ahead and tell you what the correct answers are in the feedback thing. I hope you guys are looking at those because I take time to actually grade them and tell you what the correct answers are. One of the ways to remember those 5 things is never let monkeys eat bananas. Okay, so the little acronym. So never let monkeys eat bananas. That can kind of help you. Once you get them maybe all written down or whatever, then you can kind of resort them. I kind of like them more in this order, with the neutrophils, the eosinophils, and the basophils kind of listed first. Neutrophils are your most abundant, and then your lymphocytes and your monocytes, obviously the suffix on them is a little bit different. So I'll be talking about each one of these individually, but here's a little reference table here about approximately normal values for those, and as you can see, the neutrophils make up the greater percentage. Again, chapter 7, Wilkins. Alright, so your neutrophils make up about 40 to 75% of your total white blood cells. So you will definitely see an increase in that count if you have an infection going on. They are your major line of defense. They're your first line of defense. Okay, they are produced and stored in the bone marrow. There's a question on either advanced patient assessment or regular patient assessment about it being like the last line of defense. It's your first line of defense. So they're produced and stored in the bone marrow where it matures and waits to be called into action. So they're your big fighters. And that process can take up to 8 to 12 days, but there's actually a way that it gets sped up if need be. So then once the neutrophil leaves the bone marrow, it enters into the circulating blood, and it has a pretty short half-life, only like 6 to 8 hours. Then it marginates through the wall of the blood vessels and into the surrounding tissues. And once it's in the tissues, then it participates in phagocytosis. So I always picture phagocytosis as like, I don't know if anybody remembers like little Pac-Man. It was one of the first, probably now you guys are all too young, but it was one of the first kind of video games they came out with, and it had like just this little circle guy with like a mouth, and he would just kind of be eating little things along the way, kind of like a little pathway you'd have to follow back a long time ago. Anyway, so I think a little phagocytosis as these little Pac-Man guys kind of eating up the infection basically. And then they die, the neutrophils die. The normal lifespan then is about 10 days. So neutrophils are classified as bands and segs. Okay, bands rather are immature neutrophils. They don't have a nucleus and they have not been segmented. And then segs then are your mature neutrophils. Most of your neutrophils are segmented. But when you see an elevation, and if you look, I don't know if this one did it or not, I don't think this one, but I know one of the other, when we talk, so we kind of go over some of the stuff again in advanced patient assessment, just a little bit deeper and a little bit more application of it. But I just want to say that if you have both of them elevated, there's generally a severe infection going on. It's kind of called those neutrophils into action. They can actually speed up the process, and then the band level will also be increased because they can differentiate the bands and the segs within the neutrophils themselves. All right, eosinophils and basophils and lymphocytes. So your eosinophils, when you see eosinophils, you should think asthma. So if there's an elevated eosinophil level, it's generally an asthma or allergic reaction or parasites. Okay, so the associated with elevated asthma, allergic reaction, parasites, so eosinophils, kind of get that in your head. Basophils will also play a role in allergic reaction, so they're both with allergies, but eosinophils for sure in asthma. Lymphocytes And we'll talk about some of the different terminology as far as which means increase or decrease. Lymphocytes is you're looking at increased in viral, fungal, and other infections. It can also be reduced in immunodeficient patients. So there's 3 different major types of your lymphocytes. You have your T cells, they're most common for eliminating viruses, your B cells, which help with your immunity, antibody producing cells, and then your NK or your natural killer cells. They help destroy certain viruses and tumors, and like cancer. So your monocytes are actually the largest in size of a white blood cell. They're the biggest cell with size. And when you think monocytes, you think chronic infections. So when you think of neutrophils, you think bacteria. When you think of lymphocytes, you think viral. And when you think monocytes, you should think chronic. Okay, chronic including TB. I do know that's a test question. So TB. Also typhoid fever, syphilis. So in the lung, the monocytes convert to a macrophage, and then they actually play a key role in clearing up the lung of like inhaled particles by that phagocytosis action. I know, lots to know. So leukocytosis is just basically your term of meaning an increase, an abnormal increase in your white blood cells. Okay, so leukocytosis is a high white blood cell. Leukopenia is a decrease in white blood cells. And then when you're looking at your neutrophils, so white blood cells as a whole, now the differentiation of them would be your neutrophils. Neutrophilia is an increase in the leukocytes due to the neutrophils. So you're going to see a high level of neutrophils when they're doing that differentiation in response to an acute bacterial infection such as a pneumonia. Also, though, can occur in fungal, parasitic, viral infections, burns, any kind of stress that's going on in the body, surgery burns and MI, sometimes anesthesia, and that should say stress, actually. A couple different typos so far. Neutropenia then is a decrease in your white blood cells. Okay, so there's a decrease in white blood cell due to the decreased neutrophilias, because remember your neutrophilias make up the biggest percentage of your white blood cells. Neutropenia, so if you see neutropenia, you have to be concerned that your patient has an impaired ability to fight off infection. Okay, sometimes they put patients in neutropenic precautions because they don't have the fighters available to fight off infection. So we'll put them like neutropenic precautions, or they might even call it reverse isolation, where you need to wear a mask at the minimum, sometimes gloves. You have to be careful on giving somebody something transmitting a nosocomial infection within the hospital or hospital-acquired infection. So those are usually patients that are undergoing chemo or they have leukemia. So make sure you just are kind of familiar with all these different terminologies. Go back through your textbook. I want to make sure it's in chapter 7 in Wilkins. I have some side notes here on but I also had the old book there for a while. Yeah, 124 and 125, that's the current edition that you guys are using. So, moving on to platelets. So platelets, again, are a formed element. They're the smallest. And those platelets are also called thrombocytes, because remember, thrombo is clot. They're small, they're colorless. The cells are fragments that help form the clots to prevent bleeding. So some of the terminology is thrombocytopenia, which means a reduced platelet count. Okay, so sometimes that can happen if they're certain medications, if they're getting chemotherapy. diseases of the bone marrow. So we have to be concerned with those patients because they have a tendency to bleed. They're not going to clot. So normal platelets, if I remember right, are like 150 to 400,000, something like that. I'm sure it's in your book. I know it is. But you'll often hear it referred to as like their platelets are 100. It doesn't mean that their platelets themselves, yeah, it's 150 to 450,000. Okay. Or their platelets are 50. It doesn't mean they're 50, they're 50,000. We really need to be concerned if they're less than 20 or less than 20,000. And like when we're drawing blood gases, and we, if their platelet count is low, then we're going to probably have to hold that blood gas site for a little bit longer after you've drawn that blood, so they don't get a nasty, bruise, what we call it, a hematoma. It can really, get raised and a big bump, and because it's the artery that you just punctured, so you want to hold it really well for at least 5, 6, 7 minutes, and just kind of keep watching it, kind of look at it. Thrombocytosis then would be an increase in the platelets. Sometimes this can happen. It's a reactive process after surgery or a hemorrhage, splenectomy, stress or inflammation. So there is where you want to be careful because they're going to form clots easily. So be aware of a possible PE or an MI. These types of patients might need blood thinners like heparin or Coumadin, so they don't form dangerous clots. So I was just looking at my slide count. We're getting there. So hemostasis, those are different coagulation screenings that we can look at. We can look at their platelets, we can look at the APTT, the PT, the INR. I'm not going to go into a huge amount of detail because we actually go into that a little bit more in advanced patient assessment, but they're just basically, the platelets themselves, and then there's also other parts of it that you can kind of look at. This actually screen came from the publisher. So we're basically looking at how fast their blood can clot. D-dimer is a test that they do, kind of is produced as a result of the breakdown of the fibrin clots that form vasculature, so that form in the vasculature. So that's another test they may do if they're looking at blood clots, especially if they're trying to rule out a PE, is looking at their D-dimer. Moving on to the chemistry part of the blood, so your BMP would include your electrolytes, your glucose, your BUN, and your creatinine. And we're going to go into these a little bit more. So the electrolytes that we're going to be concerned with in this class is going to be your sodium, your potassium, and your chloride. So sodium is a primary cation. In normal values, 135 to 145 milliequivalents per liter. Your sodium concentration is regulated by your kidneys. Some of the terminology here and what it's caused from. So hypernatremia. So natremia is your sodium. So you have a high sodium count. You could be dehydrated. This is pretty much your big cause here, depending on how you're losing your water. It could be sweating, diarrhea, renal diseases, so where your water intake is insufficient, so your sodium is higher. And the flip side, low sodium, hyponatremia, would be excess water intake or retention. So again, this could be a kidney disease, could be adrenal gland impairment, or you're just losing sodium for some reason. And I think this is one of the ones to be concerned of. I want to say, I think it was one of those like party drugs or something that people were taking, where they were, it makes them like really thirsty or something, and it can actually dilute the amount of sodium. And then if your sodium is too low, I'm trying to remember if it was the sodium or the potassium, but one of them, because they definitely have to do with potassium more so really with your cardiac muscles. Maybe it was potassium. Maybe that was the one. It was one of those like drugs, like rave. I don't know what they even called it, but that they were slipping in people's drinks and making them drink too much. So whatever the important electrolyte for your heart, which is probably most likely potassium, it was causing these people, young people, to go into arrest, cardiac arrest. Always watch your drink out there. Anyway, that was always one of my words of advice to my kids. I know you're probably going to have a drink, but just make sure you watch. Don't leave your drink unattended. All right, potassium. So potassium, again, is also a cation. The normal value is about 3.5 to 5 milliequivalents per liter. Hypokalemia, so you have a decreased intake or an increased loss. Again, either one of these on either a high end or a low end can lead to cardiac dysfunction. So we want to make sure our potassium. So hypokalemia, then, even though it's K is potassium. Okay, that's some of these words and some of the symbols, and that can be kind of confusing. But hypokalemia, you think of K is potassium. So again, from chapter 7, so if you have a decreased potassium intake, obviously you're going to have a low potassium level. Maybe it is your diet. Alcoholism can cause a low potassium. Increased loss of potassium can cause a low potassium level with GI loss, renal disease, diuretics. So some diuretics are potassium sparing, but like I remember when my mom was on a diuretic, she had to take potassium supplements because it kind of washed out her potassium at the same time. So that's a thing that they'll monitor if you're on those medications. There can also be a shift from extracellular to intracellular potassium, and those can be caused from alkalosis, increased plasma insulin, diuretic use. But just kind of know potassium has to do with the skeletal and cardiac muscle function. And then we have some reasons for increased potassium hyperkalemia. I'll let you kind of take a look at those. So how this all can be kind of applied, and we're talking about some of these different blood levels. So some crushing injuries, or even crushing injuries are one of the causes, but another one is if patients are found down, like you always hear the story of haven't heard from somebody, they didn't come to work or whatever, or family members trying to get a hold of somebody, and they found them down at home, and they'd been like that for 10-12 hours or whatever. And so what happens is that the muscle tissue breaks down. And crush injuries, like a motor vehicle accident or something, it can also happen where the muscle tissue is breaking down and it releases protein that can actually clog up your kidneys. Okay, so sometimes this happens, and these patients actually need to go on dialysis. So it basically clogs up the kidneys and makes them not functioning. So there's this continuous pressure is placed on the tissue, which causes ischemia, leading then to muscle injury and cell death. The muscle injury causes large quantities of potassium, phosphate, myoglobin, creatine kinase, and urate to leak into the circulation, and the large quantities of this clogs up basically your kidneys, and then it kind of creates a bad cycle where it increases the metabolic acids, which lead to metabolic acidosis, which leads then to breathing problems, more energy expenditure, and more lactic acid buildup, and it just kind of creates a bad vicious cycle. So that's what they'll call it rhabdo. You might just hear it called rhabdo, but it's rhabdomyolysis. And I have definitely seen it in patients that have been found down at home for a while. All right, chloride is another one that we look at. Be familiar, with the normal values. Hypochloremia, low chloride levels, severe vomiting, chronic metabolic alkalosis. Hyperchloremia can be caused from certain kidney diseases and prolonged diarrhea. I'll talk more about chloride when we get to advanced patient assessment. So for your renal panel, this was another question, your BUN and your creatinine are the two that you kind of, so if you said renal panel, you're fine, but specifically BUN and creatinine. I need to actually rewrite that question so it says 2 because I want both of those listed. So these are your two most common tests to check your renal function. Basically, if they are elevated, it means your kidneys are not functioning properly. So you'd have elevated BUN, like 25 or 30, and your creatinine would be elevated. That would be showing possible renal failure. It's kind of interesting. It says neither test is sensitive to early kidney disease, but your glomerular, your GMF, GFR. I'm sorry. I have to what are the letters again? Glomerular filtration rate. So your GFR. But I'm not going to expect you to know that. But we do talk about advanced patient assessment is actually the test that you would use for that glomerular something filtration rate. Heart failure can also elevate your BUN. So again, kind of putting all the pieces of the puzzle together. And then your analysis is just kind of looking at like a quick dip of your urine. This is something done sometimes in the doctor's office. It can establish your hydration status, if you have glucose in your urine, proteins in your urine, blood in your urine. All right, glucose now. Glucose, we should know, is needed to create energy. You'd like to have a normal level of about 70 to 99, 100 I think I've seen too. I mean, if I test you on these numbers, I'm not going to be that super picky. Like if you said 100, I wouldn't mark it wrong. Generally 70 to 100, I think that's easier to remember really. An elevated glucose then is considered hyperglycemic. So type 2 diabetes patients, you might see this in, and hypoglycemic. That's definitely something that they check when a patient is unresponsive. That's probably one of the first things they do. They do that right away, like the EMS. They'll just do a quick finger poke and check their glucose level, because there's a lot of diabetics out there. So you can see it from either way. If they have given themselves their insulin shot, but they haven't eaten for some reason, they're not feeling well. So severe hyperglycemia, though, on the other end, when you have the higher sugar level, can occur with metabolic acidosis with the DKA patients, or diabetic ketoacidosis patients can be metabolically acidotic, and they will present breathing harder and faster. They have kind of a fruity smell to their breath. Sometimes you'll be called down to the emergency room to draw a blood gas on a patient that appears that they're in no distress at all, and you're wondering, why am I drawing a blood gas? You might note that the respiratory rate's up a little bit, but they don't look like a typical patient that's really struggling to breathe, like a COPD patient. A lot of times they're younger patients. I know I've drawn them on 20-year-old and patients in their 20s and their 30s, and it's like, and I'll usually ask, oh, are you a diabetic? Sometimes you don't get the reason as to why you have these orders to do things. If you're uncertain if it's an appropriate order or not, don't be afraid to ask the physician. But that's usually one of the things. If I see the patient, I'm like, well, this isn't a COPD patient. This isn't anybody in really obvious distress. So I'll say, oh, are you a diabetic? And they'll usually always say yes, and that's what they're checking for, is DKA. And some of them have gone through it before, and they know the drill. All right, so stress-induced, this can actually happen. Hyperglycemia can happen in patients that have trauma, burn, sepsis, or surgery. The glucose then is produced at a significantly higher rate to account for all the increased energy expenditure that's happening as a result of the stress. And so we have to be mindful of that, watch their glucose levels, because we don't want them to go into DKA, and which, if left untreated, could lead to coma or death. All right, albumin. Albumin is a protein. Albumin helps regulate that oncotic pressure, helps keep the water within the vascular space so we don't have leaky vessels going on. It's a primary role in lipid metabolism. We can see hypoalbuminemia in patients that are protein malnourished and liver disease. We need to be mindful of it because it also can cause pulmonary edema if they have a really low albumin level. So understand what albumin means. It's part of the hepatic panel. Oh my goodness, my tongue is in a knot. All right, enzymes. Enzymes are responsible for our chemical reactions. Keep in mind that most of you, pretty much all enzymes, end in ASE. Okay, so you have aspartate, aminotransferase, and then you have creatine kinase. So all enzymes pretty much always end in ASE. So that's kind of how you help identify, like pancrease is a pancreatic enzyme. So they're responsible for chemical reactions. If you have a high level of AST, it could indicate hepatitis. It often can be used as a biomarker on the second day after an MI. It used to be used as an acute MI, but now we have troponin and one of the biomarkers that we use instead. Creatine kinase are also elevated in MIs and various types of skeletal muscle diseases. If you're breaking that down into your body, it will show up. It's basically a muscle breakdown byproduct. So if your CK is elevated, that might mean there's some muscle damage going on somewhere. So it's usually heart muscle and skeletal muscle because those are the similar type of muscle tissue. Lactate is another one that they really kind of look at in the ICU, especially because it's a common cause of lactic acidosis from anaerobic metabolism, from tissue hypoxia. So you'd like to have a low lactate, reference range of about 1.7 to 2. A lactate level of greater than 2 millimoles is what that is associated with a higher mortality of patients with sepsis, trauma, or cardiogenic shock. It's the end byproduct of anaerobic glucose metabolism. So they monitor lactate levels in the ICU, especially on our septic trauma patients. Troponin is one of your more common cardio biomarkers, and there's kind of like 3 different types here, but just know that troponin, it's a complex of 3 different types of proteins. It helps regulate muscle contraction, normally is present in small quantities, and if you have an elevated troponin, then it could indicate an MI. It's your troponin 1 is considered the more specific one used for diagnosing an acute MI. And then BNP is another test that they can do, a B-type natriuretic peptide. It's a cardiac neurohormone, and it's kind of one that they use to help diagnose CHF. So they'll kind of look to see what the BNP level is, and you can see that fancy chart there that the physicians are probably well aware of. The higher the BNP level, the more likely there could be in heart failure. So looks like greater than 500. So used to diagnose CHF. Okay, so make sure you check out again Chapter 7 in Wilkins, and I will make those adjustments on the MRE when I finish grading them. I'll see you guys all on Monday also.